Hello, my name is Mike Hess, and I'm a respiratory therapist with the COPD Foundation. As you probably know, inhaled medications are a foundational therapy in the management of respiratory conditions like COPD. But on the flip side of that, there are a lot of barriers that prevent patients from adhering to their medication regimens, and of course, a lot of barriers that healthcare professionals face in prescribing them in concordance with best practice strategies. So I'm very excited to be joined by two outstanding clinicians and subject matter experts in the area of inhaled medications. Joining me today first is Dr. Jill Ohar, professor of medicine at Wake Forest University School of Medicine in the Division of Pulmonary Critical Care, Allergy, and Immunology. She's been a primary investigator of several previous and ongoing COPD clinical trials, as an investigator on the current Spiromic COPD population study, the author of dozens of book chapters and peer-reviewed articles. And in 2019, she received the Sridhar Lifetime Achievement Award in COPD from the American Thoracic Society Clinical Problems Assembly. So welcome, Dr. Ohar.
Thank you. Thank you. It's great to be here.
Also with me is Dr. Roy Pleasance II, also known as Roy the Inhaler Guy. Dr. Pleasance is a clinical researcher with both the Morisco Lung Institute and the University of North Carolina, Chapel Hill, and with the Division of Pulmonary and Critical Care Medicine at the University of Michigan. He's taught and practiced pharmacy since 1985 at various academic centers, including UNC, Duke University, the Medical University of South Carolina. Has written COPD management strategy recommendations for the National Heart, Lung, and Blood Institute, the Centers for Disease Control in 3 different states. Also well written with many peer-reviewed publications and chapters. And current projects include working with several organizations to establish updated national guidelines on aerosol delivery, as well as a new web-based training program on aerosol delivery for prescribers and office staff in pulmonary practices in North Carolina. So, Dr. Pleasance, thank you for joining us.
Thank you. I really appreciate the opportunity to do this, Mike, and particularly to do this with Jill. You know, we've been colleagues for, I think, about 15 or 20 years, and we've done a lot together. And anyway, it's really a great honor to represent sort of the aerosol world today. So thank you.
All right. So our objectives today are to kind of educate and then reinforce optimal activities for prescribers to help them make the best possible prescriptions, as well as our friends in the allied health world, like respiratory therapists like myself, as we're making delivery or care plan recommendations and that sort of thing, so that patients can receive the right treatments at the right time and in the best manner. So let's go ahead and jump right in. Dr. Ohar, I'll start with you. This may be a controversial question, but I would say, I would ask, in your opinion, what is the best available aerosol delivery device?
My perspective on that is there is none, and all of them are. And that is to say that each of the devices has its attributes and has weak points. And just like our patients each have their individual attributes and their weak points. And so matching the device to the patient is really the critical step.
Dr. Pleasance?
I concur with that. I mean, really, you know, we have, depending on how you define it, 4 major groups of devices now, and many of the inhaled medicines that we have available come in each one of those, but not all. I mean, there are some limitations. I think they all have a role, and I think we'll talk about that more in detail.
Yeah, let's actually go ahead and touch on that. What are some of those key factors that you would want to consider as you're trying to come up with a personalized prescription for folks? What are things that clinicians should be taking into account?
I think that when we look at our patient, we should look at what are their attributes and also, as I say, what are some of their weak spots. So if you had a frail little old lady, you may want to stay away from a DPI, a dry powder inhaler, because often they are unable to produce the force required to effectively activate an inhaler device like that. Whereby the DPIs are actually my go-to with many of my patients because they're so simple to use. You flick them open, you exhale fully, away from the inhaler, you put it to your mouth and you inhale as hard and as fast as you can. Now, and Roy had already mentioned an MDI with a spacer, and I think that the MDI with the spacer eliminates or avoids many of the coordination issues that are so critical with the use of an MDI. So, but if you had a patient who had severe coordination issues or severe hand disabilities, either from weakness or from arthritis, etc., you would probably say, maybe I want to go with a nebulizer instead. People who have severe cognitive issues and can't even coordinate with an MDI with a spacer, that's where my go-to is a nebulizer. Sometimes they can get away with a soft mist, but which actually helps to mitigate some of the coordination issues that are required for a metered dose inhaler. But I think, you know, when you stop and you say, okay, what are those factors? So with a patient, it's cognition, strength, coordination. Probably first and foremost, which I didn't even mention, is the idea of cost and availability.
So this is the way I sort of try to put them in order. So first of all, it's pharmacology. And so I think, you know, most prescribers, I'm not a prescriber, but I'm a recommender, sort of an expert, but most people want to think about pharmacology first. You know, what type of drugs do they want to use? And then probably the next thing is, you know, what is it going to cost the patient? Is the payer going to cover it? I mean, I think that's oftentimes the thought process. And then, as Jill alluded to, like the patient's abilities, you know, can they use that MDI? Can they do all the stuff that they need to do for a nebulizer? You know, do they have access to a spacer? And I think the patient's experiences. So, you know, if they used a particular type of inhaler before and it worked particularly well or particularly bad, or they had side effects, you know, I think that's going to be a key driver, although I think that's sort of probably not the main driver of decision making. Then what's the goal of the device? You know, are you using it chronically? Or are you using it intermittently in that patient? So I think that's something to consider, you know, in terms of, you know, what are your goals in that patient? Is it a controller? Is it a reliever? Should it be both? So anyway, those are some of the things that I think about in device selection.
Great, thank you. I was going to ask if patient preference had any part to play in any of that conversation. So I appreciate you jumping in on that.
Yeah.
You know, we also know, though, you know, as we try to set up our patients for success, we know that inhaler technique errors are extremely prevalent. You know, there's in 2016 there was a paper that came out that showed us that inhaler rates have been error rates have been essentially unchanged for the last 40 years or so. So with such a critical device, why is that? Why do we have such a persistent string of errors?
I think, you know, first off, it starts with the teachers. So, you know, as you've already demonstrated, there's a large error rate, and even healthcare personnel fall into that realm, that we as healthcare personnel, and whether that's physicians, whether it's pharmacists, whether it's respiratory therapist, whether it's nurse, practitioners, nurses, nursing assistants, all of these would be very useful types of patients, or sorry, types of healthcare personnel that could demonstrate to our patients the proper technique. So we don't know, number one. Number two, we as healthcare personnel don't know. Number two, time. Patients are shuffled rapidly through an outpatient practice and with little time to have them demonstrate their technique and to work constructively with that technique. Number three is payment. You have to pay the people who are teaching, and you know, finding a diagnosis code that will actually get reimbursement is also critical.
So I think the first point that Jill made is a great one. Because one thing that hasn't changed in whatever 40 years, or hasn't changed much in 40 years, is really proper education of the healthcare providers. And certainly the typical physician, even specialists as allergists and pulmonologists, are either not trained or they're not trained well. So one of the things I'd like to share with you is a survey that I did in preparation of this web-based training for pulmonary fellowships in the country. Was we surveyed 50 pulmonary fellows at these, I think six different training programs across essentially Eastern US. So this question was, of these 50 fellows, which of the following did you learn about inhalation devices? And so basically the first two bars up there at the top, it was some sort of dedicated teaching effort, like a structured lecture, structured workshops. But the biggest way people learn was on their own in the clinical setting. And then, literature or maybe some informal. So anyway, it's really lacking. And it's really hard to build in this sort of training into these fellowship programs because they just try to teach them so much. And quite honestly, I think they spend too much time on the detail and they sort of forget asthma and COPD to some extent, because that's what a lot of the practitioners, when they go out in community practice, is a ton of asthma and COPD. So that sort of fits along with the lack of education in inhalational devices. So I think that's really we need to do a much better job of this. I know in pharmacy schools they do a decent job, and obviously in respiratory therapy training programs they do a decent job, but probably all the other healthcare professions, it's lacking tremendously. And that's one of the reasons why the group that I'm involved with, the North Carolina Thoracic Society, we have begun developing and pretty far along in developing this web-based aerosol training program for the office staff, because as you know, during the pandemic and after the pandemic, people are in like the styluses at the subway. Just having trained staff is a big problem. So we're targeting not only the prescribers in those practices, but also the office staff who are critical in that. So I think that's something. Another thing is just lack of placebo devices. You might have an ellipta today, but anyway, it's just, and the patients oftentimes don't bring in their inhaler. So oftentimes, if you do have a device to teach them, you variably have that device. So I just think the tools that providers need, and then as Jill alluded to, is the personnel and then the reimbursement. What I do know is that not all payers cover for inhaler teaching, and not all payers are going to pay for repeated education, which is critical. So I'd see some of those barriers, but really things have the same barriers we had many years ago. So we have to do something different, and I think there are some things in the horizon, that will hopefully help with that. But I think educating the providers and then putting tools in the providers in patients' hands, I think is the way to go. So.
I want to jump in here right now and mention that as enforcement for what Roy just said, there was an article in the Annals of the American Thoracic Society in 2016 by Press that showed that inhaler technique after teaching does improve and then it decays. And so the whole point is to not only teach, but reteach and then repeat and then reteach, because otherwise the efficacy of the teaching begins to wear off over time.
So, and that sounds like that can also lead into adherence issues. Again, we know not only are there problems with technique and technique decay, we know a lot of folks end up just not taking their meds after a while. So do those problems go hand in hand, and how can we work to address those as a healthcare system?
I can't help but wonder, and we know from pharmacy literature that that the refill persistence rate is at best with these controller medicines about 30%. That means that patients, a little less than a third of the time, persistently use their controller medicine. And I can't help but wonder, if you're a guy who can't coordinate to use your MDI, don't know to put a spacer there, aren't strong enough to use your DPI, can't figure out how to assemble your SMI, etc. And so you get little to none of what's in that canister or device. Why would you persist in using it? You don't get any of that benefit or very little of that benefit. And finally you go, oh, it's not worth it, and that's it. And so I do think that they actually do. They're intimately linked and inextricably linked.
Yeah. I mean, I think adherence and technique are the two big problems with aerosol drug delivery as a whole right now. But having said that, I think our definition of optimal adherence is evolving over time. I think it's particularly evolving in asthma. Now, in COPD, I feel quite confidently in saying that these patients really need to be adherent with their daily controllers. I mean, that is a population where they really do need to be using it regularly, more so than they oftentimes do. And I just sort of throw this in here as a consideration that a lot of people don't even think about is, well, if they're not adherent with that inhaler, how long is that inhaler good for? Okay. A lot of patients, and essentially all patients nearly, and essentially all healthcare professionals, they look at that expiration date on the inhaler. Well, that's the expiration date. Well, guess what? You take that ellipta out of that package, it has a desiccant in there and it's air sealed. It's good for 45 days. So if they're non-compliant, at 45 days, it's not like the drug is going to quit working, but at 45 days, the potency starts declining. So I think, that is an issue with adherence that is really not discussed. And I think that sort of brings in, well, maybe a capsule DPI, because you're going to have stability because that capsule's in this foil thing and you take it out and you use it, or a nebulizer. I mean, what the real expiration date on that ampule is. That's real. I mean, that's what you can rely on. But the inhalers, the real expiration date, it is not what's written on the inhaler. So as far as adherence, it's just, well, they're not adherent. They're not going to respond as good. And then if they're not adherent long enough, well, all of a sudden the drug doesn't work as well as it used to. And guess what? They dump a lot more in their mouth because now the particle size has gone up. So side effects will go up. But if a patient's having problems breathing, it's sort of like, well, is because the inhaler's not working because my breathing, or is it the inhaler? So it's very hard for patients to sort out. So I think you have to go after adherence and technique. Adherence is very hard to document other than patient self-report, and they always overestimate. And technique, you can observe it, it declines. I think for inhalers, I think this can be addressed with digital inhalers, both adherence and then at least some of the devices with inhaler technique. So in any event.
Yeah, I want
So
to amplify on that one too. So number one, I really didn't talk about cost again. That keeps raising its ugly head. But a lot of times patients feel that if they take a BID med once a day, it'll be enough and they can preserve the inhaler for a longer period of time without having to worry about the additional cost of buying new. That's number one. Number two, I was going to get into the electronics, the idea of a virtual visit, which is wonderful because first off, you see the patient in their environment. And number two, when you say, well, let me see you use your inhaler, they can't say, I left it at home. They can say, I left it in the bathroom, and you say, okay, I'll wait, go get it. And then number three, in terms of remote monitoring devices and self-reporting devices, and we've had experience, both Roy and I both have had experiences, and we're working on a manuscript right now with data we reported at last year's ATS. And so some of these remote monitoring, self-reporting devices can tell you, well, did the patient really take it? And indeed, we found that if they said they took it, now they realized that they were being monitored, but if they said they took it, they really did take it. So that was number one we found out. And number two, I think because the patients in some of these devices actually can see their dashboards, they get feedback on their technique, which is really kind of interesting. And we were able to show in an exacerbation enriched population that that you can actually, even based on their use patterns, predict an impending exacerbation. So I think all of these are really exciting places to go in medicine right now, the electronic edge, as it were, for the care of patients.
So given that all of that technology is not necessarily in widespread use, and given that we have, again, tremendous error rates with inhalers and things like that, we haven't really talked about nebulizers much, but nebulizers don't generally require any kind of special breathing technique or anything like that. Should clinicians more strongly consider nebulizers as part of the regular maintenance or regular treatment plan?
I'll start. So just to mix it up a little bit. So one thing is, we did a little bit of prep meeting yesterday, but Jill was reporting, I think about 60 or 70% of COPD patients have nebulizers. And so I went and looked, at least for advanced disease asthma patients, or the very young or the very old, somewhere around 50 to 60% already have nebulizers. So I think that's key, in deciding whether to use a nebulizer if they already have one. So any event, so to me, there is a cost factor for some nebulized drugs, right? And then that's also relates to whether Medicare A and B covers, insurers and so forth. But as far as choosing, I'd say, inability to use a handheld inhaler, I think a nebulizer is great. And, I'll never forget this my whole career, but I just remember one of my colleague pulmonologists at Duke says, please go in there and train the patient how to use this inhaler. And it was a lady, an elderly, frail lady, probably 85. And she just looked up at me with her eyes and she couldn't even respond. I mean, it's just, of course, you're not going to do an MDI of a spacer. So I walked back out and I said, hey, we need a nebulizer. So, and also the hospital setting, I think the unit dosing of nebulizers is a growing sort of phenomenon in the country, rather than paying for a 1 week or 2 weeks or a month supply of an inhaler. Why don't you just unit dose that albuterol, ipratropium, formoterol, anticholinergic? And I think that data is pretty strong. It is cost effective. And then I am not a big fan of dry powder inhalers in the hospital setting at all. The patients are sick, their PIF drops, they're just laying there oftentimes when they do their inhaler. So I am not a fan of DPIs. I'd much rather see a patient get a nebulizer than a DPI any day in a hospital setting in terms of patient has respiratory compromise. I think immediately post-hospital, I think some of the work Jill did and Don Mahler, excuse me, Don, but anyway, just post-hospital, the data's pretty doggone strong. I think a lot of it's just logistics, right? Getting that patient out the door, they have a nebulizer. And another one I think is really underutilized is nebulizers for high-dose inhaled steroids in order to avoid prednisone in people. And it works really well, but it's a little chunky. But I would suggest to you prednisone 40 a day for 5 days. It's no better than budesonide nibs, 2 milligrams twice a day for 7 days. It's no better. You have a lot less effect on blood sugar and probably heart failure. So I'm a big fan of nebulizers and COPD patients at home, and actually asthma patients as well, sort of get on to that exacerbation without having to use prednisone. So I consider nebulizers as a prednisone sparing treatment.
So very contextual depending on the setting, not only the patient needs and abilities and things like that, but the setting also. Dr. Ohar, how do you feel about that?
Well, I agree with everything that Roy said. I think that, nebulizers, first off, I think it's actually a COPD Foundation study that showed that somewhere around 80–85% of COPD patients have a nebulizer or access to a nebulizer at home. And while they generally use it for flares and for rescue drugs, there's a reason why people feel more comfortable that the nebulizer delivers more reliably their meds. And it's that kind of endogenous feeling when you talk to patients, they know they can rely on it. They know they get it when they get into the hospital. And so I think that, again, certainly for the older, frailer, more challenged, either intellectually, dexterity-wise, strength, etc., that the nebulizer is your go-to. We published in the Annals of American Thoracic Society that over 50% of people coming out of the hospital have a reduced PIF, peak inspiratory flow. And so, you worry, that's when people, remember, what's the best predictor of a COPD exacerbation? A previous exacerbation. And not only that, but an exacerbation is a harbinger of death, mortality. 1 in 4 to 1 in 5 people who have an exacerbation that requires hospitalization are going to be dead in a year. I mean, these are pretty stark statistics. You see patients in the hospital and you say, and they go, "Doc, did I have a heart attack?" And you say, "No, you had a COPD exacerbation." And they go, "Oh," and actually the mortality rate's worse. So, so I think, providing a nebulizer treatment during those periods of extreme vulnerability, 6 weeks after an exacerbation is the greatest risk for a new exacerbation. That's when we really, really need to use it. And then in addition to that, all of those people who may have flaws in their ability to use some of the other devices.
Given that we use nebulizers so often, you've mentioned the hospitalizations and then the immediate post-hospitalization period, we use them so often in those time frames. Is there maybe a perception, or I should say a misperception, of nebulizers as just being for emergency or acute therapy? Do they have a role in chronic care?
Yeah, I think they do. And I think patients do associate, I'm really sick, I need to use my nebulizer, rather than my nebulizer is a dependable way to dispense my medicines that I can get them.
Yep, it's quite nurturing, I would say. I mean, I've always talked about the magic of medicine, and I think nebulizers are sort of nurturing, and they quite honestly, I always felt they had a little magic to them in terms of patients' response or how they felt in using this thing. It sort of sounds smooth, and the particles are moving out. I mean, I don't know. It's almost a bit nurturing. And that's hard to put a label on, but I think it's very real, sort of thing. To me, the one thing, as probably many of the audience know, is there's going to be increasing number of drugs given by nebulization for COPD. In fact, one will probably be available sometime later this year. So I see nebulization as sort of a growing pharmaceutical market, particularly for drugs that are targeting the elderly, primarily because of Medicare A and B, I think. So I think we have, right, in the very near future, we're going to have a brand new option as far as, adding to the other drugs. And so guess what? It would be certainly very convenient, if you're on a LABA or a LAMA, and that, gosh, let's also add this other nebulized drug that works by a different mechanism. So I think they give a little more flexibility over time. The downside I see is patients don't clean them very well, and they're not instructed very well to clean them. So I consider that a gap. And most patients on nebulizers will tell you, nobody ever really told me how to clean them, sort of thing. And I think that's a gap, and that's about patient education. The other concern I have is just literally how much drug ends up in the mouth. I don't think we fully appreciate the effects on oral health. When I say oral health, I'm not just talking about candidiasis, I'm talking about teeth. I think it's pretty clear now, and we're beginning to study this at UNC with the dental school. All the inhaled steroids, LABAs, and LAMAs, all of them affect salivary function, combined effective microbiome. And I think the data is pretty good. These things contribute to caries, and cavities. So I think we need greater understanding of this and what role nebulizers have or don't play. But I would say it's especially important in somebody on a nebulizer to make sure they clean their mouth out. It's not all about oral candidiasis and hoarseness. It's about mouth health. That's one little concern I have about nebulizers, because you're given such high doses there. So I think oral health needs to be monitored more closely in patients that use a lot of inhaled medicines. And again, it's about the teeth also.
Oh, and speaking of perceptions also and potential safety risks, at the beginning of the COVID-19 pandemic, there was a lot of debate about whether it was actually safe to use nebulizers, whether it was in the hospital or in the home, or what kind of ventilation was important. Are we still seeing those concerns? They still pop up from time to time on discussion boards and things like that. But from a clinical scientific perspective, are there safety concerns with nebulizers?
Well, I think there are some safety concerns, not so much from an infectious disease standpoint of you contaminating other folks. Certainly, as Roy pointed out, I think that the biggest infectious disease concern is inadequate cleaning. But actually, there is an article in Chest recently. I think it's online, available now, just focusing on some of these issues. The concept of nebs that are escaping, and for the effect on people in the room, et cetera. And I think it's a reality, but it's a very, very small concern. I mean, I think possibly for someone who's at great risk, maybe, someone standing over a nebulizer who's pregnant or who has extreme heart disease, et cetera, that may be a concern. And a lot of that can be mitigated by step away, go to the next room.
Yeah,
Right.
my take on it was a big problem during the pandemic, right? Everybody was flipped out about everything, quite honestly, including the, nebulizing in the hospitals or even home. But I think pretty much, the world's experts say there's no real evidence to say that it is a problem. But, conservative behavior is always good, sort of thing. And I think there are nebulizer devices that less drug is put into the room. But I think now, many of us much less concerned about the pandemic, except for probably the intensivists like Jill, where they're still seeing a fair amount of COVID in the ICUs. But I think that concern has gone away, and that really cleaning these things. Rajiv Dahan, he's one of the aerosol drug experts in the world. He's at University of Tennessee, Knoxville. But in any event, he's got pretty good studies saying after about 5 or 7 days, maybe even 4 days in the hospital, these bacteria, germs get in there and they actually bore into the plastic tubing. So really close attention needs to be paid to changing out these nebulizers, in the hospital setting. The respiratory therapist should pay particularly close attention to that. And I think particularly in COPD patients, because they're more likely to get the respiratory tract infections.
Yeah, I think at the
So
same time, if they're in for an exacerbation, at the same time they're receiving high dose systemic steroids, and so they're particularly vulnerable. other factors that are critical to consider during a COPD exacerbation is that because COPD is a systemic disorder, it is associated with a disproportionately high common co-prevalence of common diseases like heart disease, kidney disease, diabetes, the metabolic syndrome, osteoporosis. And so, you know, they're in the hospital, their inflammatory pathway is jacked up, and so their comorbidities also become a bigger problem. And so it's seen that people after or within the period of a COPD exacerbation often have heart disease, myocardial infarctions, et cetera. So it's not just the COPD exacerbation that knocks them down, it's the steroids, it's the flare of the comorbidity. And so then you put them at risk for an infection. And it's like the prize fighter just beating down the poor guy who's challenging him.
So as we start getting toward the end of our time here, I want to take a look toward the future. You know, when people ask me about, you know, why are these issues so prevalent and things like that, I often say that things like inhaler education, they're everybody's job, but they're not really anybody's responsibility. You've got the inpatient therapist who's trying to teach either in the emergency room or in the, you know, at discharge. You've got the pharmacist who could be, you know, covering the drive-through and then scheduling vaccines and a dozen other things, and that retail pharmacists are doing these days, or, you know, working through mail order. The PCP, the pulmonologist, you know, they're not always enough touch points there. So how can the various elements of the healthcare system and the various clinicians involved in those elements, how can we better work together to make sure that we have a better safety net for teaching and to make sure people actually know how and when to use the tools that we give them?
Well, you know, the COPD Foundation is a patient advocacy group, and there are other patient advocacy groups. And you know, I'm a frail old woman, as Roy pointed out earlier. You know, he's talking about frail old women. So I've seen a lot in my life, and one of the things I've seen over time is that money talks. And so advocacy groups, if they could push the insurers and government Medicare, Medicaid agencies to better fund patient education, clinicians of all type would be racing to teach patients how to use their inhalers. So that's what I would advise.
I think for us to make progress, you have to start with the healthcare professional trainee level. Because if you don't train them the importance of it at the beginning, you know, you've lost a lot of ground that you may never make up. So I think you really have to incorporate aerosol drug delivery training in a number of healthcare professional programs. I think that is necessary. I think the use of technology and in not just, you know, digital inhalers. I think digital inhalers. There's two, three products on the market in the US that literally teach patients how to use their inhalers. I mean, they literally do, but the uptake on that is not great yet. And, you know, it's got a ways to go. But I think text messaging, say a patient comes in, gets a prescription filled in a pharmacy, and the pharmacist doesn't have time. Well, why don't they get a text, you know, in the next 30 minutes or an hour? Hey, you know, would you like to see how to properly use that inhaler? So I think technology is going to be key to some extent. I think, including what Jill mentioned too, you know, maybe we need to be teaching these patients virtually, and we should be paid for that. Um, so I think technology, but again, if you don't make it important during the training program, it's really hard to convince people that it's important when they're practicing. So I think that's the step number one, but it's extremely hard to accomplish.
And then stepping outside the direct clinician to clinician communications, do you have any tips on how patients and clinicians can work together to do that shared decision making that leads them to their best chance of success with adherence or maintaining their technique?
Yeah, I'll take that too. I think that it, teaching patients to advocate for themselves. So when they go to pick up that script, that device at the pharmacy, for them to ask the pharmacist, can you demonstrate this to me? Can you tell me how to use this? There's no pharmacist on earth, no matter how busy, who's going to say, no, I can't do that. That's their job. And if they don't comply with the patient's wishes to be taught, then the patient's not going to buy that script there anymore. So there's a financial incentive there for the pharmacist to teach them.
Does our resident pharmacist agree with that perspective?
Well, actually, I tried to get the North Carolina Board of Pharmacy about 10 years ago to require pharmacists to do device teaching. And it ended up being unsuccessful, unfortunately. It's all about payment, predominantly. Unless you change the payers, there is something called medication therapy management that certain Medicare patients fit the criteria that the patient spend a lot of time with them, but that's um, very small percent of patients. I actually believe this is the model I believe in. So you've got a prescribing physician that oversees 50 pharmacists, okay? And so that physician is going to say, I'm going to prescribe digital inhalers for your patients, and I'm going to take the responsibility for prescribing them. And those pharmacists are going to use those digital inhalers for inhaler teaching. And therefore, that physician can um, bill for that inhaler teaching, and then the pharmacists get reimbursed. So I honestly believe that digital inhalers are going to be a path for pharmacists to start getting paid, but they've got to have a prescriber. So they generally don't have prescribing rights in most states. It's all about money, and getting reimbursed for it. And even in the practices, I was talking to an allergist recently. So they do inhaler training, but they don't bill for it. I mean, that's just one issue right there, that they're not even billing for the inhaler teaching. So that's a gap there. They really weren't even fully aware of, the process to bill. So
I'd like to bring that comment full circle back to the fact is that's assuming that the teacher teaches the technique properly. And as we started out the discussion today, many healthcare personnel are unable to effectively demonstrate correct technique. That article that Mike alluded to was by Plaza in the Journal of Allergy and Clinical Immunologic Practice in 2018, and it's kind of disappointing to see in print how poorly we do as healthcare personnel. My son is a triple ninja black belt karate guy, and growing up he had a dojo, and the dojo used to say, no, not practice makes perfect. Perfect practice makes perfect. And I think that's really the key issue here in training people to use their devices correctly.
And maybe one of the last things I'm going to say is that basically what I tell patients, if you don't use your inhaler correctly, you're probably going to get some clinical benefit, but you'll get more clinical benefit if you use it correctly. And you're less likely to have side effects in your mouth if you use it correctly. So I think that's a very simple message. It acknowledges that, yeah, I'm still responding to this drug, but it also recognizes that you'll probably respond better. And who knows, maybe some of the oral effects that you were experiencing might be less likely, or that sort of thing. So that's sort of some bottom line messages that I give to patients and actually teaching providers. So.
Well, I'm sure we could spend many more hours covering many more topics in aerosol drug delivery, but unfortunately, I think that's the end of our time together right now. So hopefully the folks out in the audience have found some pearls of wisdom throughout all of this, through the discussion today that can have a very positive impact on their practice and, of course, their patients. I would once again like to thank both Dr. Jill Ohar and Dr. Roy Pleasance for sharing your time and expertise with us today.
Fantastic.
Thanks
Thank
for
you.
the opportunity.
And then finally, I would like to invite everybody out in the audience to explore our website at www.copdfoundation.org. You'll find a lot of resources, various topics covering aerosol medications, including instructional videos, recommended treatment algorithms, all that sort of thing that can help you optimize your treatment plans. And of course, you can always contact us directly at info@copdfoundation.org. So with that, thank you for watching and breathe easy.